Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you back as I highlight an important paper from the November 2024 edition of the Journal of Rheumatology. Today I will be speaking with Ms. Dansoa Tabi-Amponsah, who is a PhD candidate, and Dr. Nicola Dalbeth, who are the first and senior authors, respectively, of our featured article titled Analysis of Gout Remission, Definitions in a Randomized Controlled Trial of Colchicine Prophylaxis for People with Gout Initiating Allopurinol. So I want to thank you both for taking the time to speak to me and our listeners on behalf of all the authors of your paper and describe the findings of your paper. So with that, we'll start. So as this is a secondary analysis of a previously published trial, can you briefly describe the aim and major findings of the original trial?
Thanks. Well, perhaps I'll start with that question. As I was one of the investigators on the original paper, this was a double-blind randomized controlled trial. We published these data in 2023. This was a trial undertaken in Christchurch in Auckland, New Zealand, led by Professor Lisa Stamp. And so this was a trial of patients who were starting allopurinol using this start low, go slow approach that we use now for gout management. And they were randomized to either colchicine 0.5 milligrams daily or placebo for 6 months. And it was a 12-month trial in total. So they had 6 months on active treatment, and then we continued to follow the participants for a further 6 months after that. They had monthly flare assessments and also serum urate testing every month until their serum urate was at target, and then 3 monthly visits with patient-reported outcomes, serum urate, TOFUS assessments. And I think one of the really important things is that we did follow patients after the study drug was stopped as well. So during the period of active treatment, so colchicine or placebo, we saw fewer gout flares in the colchicine group, as I think we would expect. But one of the interesting things was that in that 3 months after colchicine was stopped, we actually seemed to see a rebound of flares, so more flares in that month 6 to 9 period after the colchicine was stopped. So we really used these data. We thought, we had all the relevant information that we needed to assess remission, and we felt that this was an important thing to do, and that's really the work that Dansoa has done in the paper we're discussing today.
Very interesting, the results. So the current study, what were the aims, and why decide that this particular analysis was important?
So I'll just give a bit of background for our audience. My PhD is focused on remission in gout, and so a big part of that has been exploring 2 definitions of gout remission across different clinical trials. So in 2016, consensus was reached on preliminary gout remission criteria by an expert group of rheumatologists and gout researchers. And so fulfillment of the preliminary criteria requires serum urate less than 0.36 millimoles per liter, absence of gout flares, low pain due to gout score, low patient global assessment score, so less than 2 on the 0 to 10 scale, and absence of tophi. And so all 5 of these domains need to be met to be classified as being in remission. There is also a time component where the urate and the patient-reported outcomes have to be measured at least twice over a 6 months or 12 months, though the preference is towards 12 months. And there also has to be an absence of gout flares over the time period. We did a subsequent qualitative study where we asked people with gout about their thoughts on the preliminary criteria. And the major feedback was that the PROs seemed to be redundant as they were measuring the same concept as the absence of gout flares domain. And so something that we heard quite a bit was that if you have no gout flares, then you're not going to have any pain due to gout, and then you're going to have a good assessment of your disease activity. And so based on the insights that we got from that qualitative study, we became interested in simplified gout remission criteria without the PROs. So in this current study, our aim was to investigate the effect of colchicine prophylaxis on gout remission using both definitions, and also how these definitions aligned with other patient-reported outcomes. And so in this study specifically, we looked at a gout-specific illness perception questionnaire. And so we think remission can be a goal of treatment, and we think it's important to explore these different definitions of remission across clinical trials and maybe establish final remission, gout remission criteria that can be widely used. So that's our aim, and that's why we think it's important.
Yeah.
You want to add anything?
I might just follow up on that and just say that one of the concerns we had, if we aren't using the PROs in the, in a definition, are we losing the patient experience, and what do we lose by, not having those PROs within the definition? So that was an important analysis using that illness perception questionnaire and looking at the relationship between each definition and the illness perception questionnaire.
Mm-hmm.
Yeah, it's really unusual in this day and age to eliminate patient-reported outcome. Exactly. Pretty radical.
This is quite controversial.
Well, good for you. So, with that, what did you find?
So we analyzed remission over 6 monthly periods. So I'll be referring to the first 6 months and the last 6 months. And so very few participants fulfilled remission during the first 6 months using either definition of remission. And so it was 7 of the 200 participants fulfilling the preliminary definition and 19 fulfilling the simplified definition. And so from this, we know remission is very hard to achieve early on. And it was primarily due to people not meeting that serum urate domain as well as that gout flares domain. But in this first 6 months, reflecting the original trial, more people in the colchicine group were able to fulfill the gout flares domain. In the last 6 months, more people got into remission, and so that really shows that over time, people are able to achieve remission. And so 18 of the 200 were able to fulfill the preliminary definition, and 42 of the 200 the simplified definition. And so the simplified definition is actually able to identify more people in remission than the preliminary. Also, during the last 6 months, there was that discontinuation of the study drugs. And with that, we saw that significantly fewer participants in the colchicine group were able to fulfill either definition compared to those in the placebo group. And this was, of course, due to the gout flares domain. And that's because those in the colchicine group experienced more gout flares immediately after discontinuing. And that was in those first 3 months after discontinuing. And then so looking at how these definitions aligned with the illness perception questionnaire, we compared month 12 scores between those fulfilling and not fulfilling remission. And so people fulfilling either definition felt that they experienced significantly fewer gout symptoms and were significantly less concerned about their gout. And additionally, using the simplified definition, participants fulfilling that were significantly less affected by their gout. And so what this showed us was that these definitions align well with the patient perspective of disease activity, and that even without the pain and patient global assessment domains, the simplified definition is still able to capture that patient perspective, and it may actually be more sensitive in doing this than the preliminary definition.
Anything to add? No. it just strikes me though, but aren't you looking at two separate concepts? Improvement, significant improvement, we'll even say, versus remission. Those are not the same idea, are they? So you're measuring two constructs, as I see it, right? I'm not saying it's good or bad. They're just not quite measuring the same. Because if I understand your perception questionnaire, you didn't ask for remission. You had, let's say, significant improvement or improvement. And that's not remission necessarily.
Well, I think that we ask people how their state was at the time. It's not,
right.
The illness perception isn't asking about, have you improved? Have you had clinical improvement? It's actually, how concerned are you?
Right.
How many symptoms do you experience? And I think what we found in the qualitative work is that the concept of remission is actually quite difficult for patients. I think also actually quite difficult for doctors, particularly when you're thinking about management of a chronic disease, when you're not, it's not like an infection or like cancer where you have a cure or you have, ongoing disease. Actually, it is in the setting of chronic disease, actually it is a slightly different construct, but it's also a construct that we use, frequently in rheumatology, including in, thinking about remission in other chronic rheumatic diseases as well. So I think this issue of actually what is remission in the setting of a chronic disease, which is not curable, is a complex concept, I think.
I agree. It's very interesting that when we see that they aren't identical. And as you pointed out, the definition of remission, I mean, if you have gout and your serum uric acid is above the cutoff, but you're perfectly well, you really care. Your rheumatologist might care, but at that point in time, you don't care.
Well, I feel that we know that people who have a serum urate above the target are likely to continue to form crystals. And particularly if their serum urate is very high, they're going to be at risk of tophaceous gout and also tophi developing over time and joint damage. So, I feel, I think there is this real tension between rheumatology and perhaps primary care where there are different priorities around, I think as rheumatologists, I agree, I think we become very fixated on the serum urate without necessarily thinking about other aspects of the disease. So, I think that people sometimes within rheumatology are, so long as the serum urate's at target, we don't, it'll all come right. When actually, if the patient's experiencing flares all the time, it's not okay.
Right.
And I think that actually the remission criteria is a really great way forward because it captures both the symptom experience of the flare, which is incredibly important to patients, but also the underlying basis of disease. So I think actually it has a lot of strengths rather than just focusing on flares or just focusing on serum urate.
I agree. I mean, as a physician and somebody with gout, I understand completely, but the concept, but that's because I understand the long-term consequences.
But I feel like it's our job as physicians
I agree.
Be helping the community and individual patients to understand that it's not just the flare. Actually, there is effective treatment, and I think these beliefs about it's just the flare actually often mean that people don't receive good care.
I understand completely, which leads perfectly into the next question. So, leading to trials and clinical practice, which may sometimes differ slightly because they have really different aims. So, which definition do you believe should be used in trials? Does it matter? And what about in clinical practice?
So I can speak to its use in clinical trials, and maybe Nicola can hop in on the clinical practice aspect of things. So I think we would say the simplified definition should be the one used. And because across our analysis of clinical trial data, is shown to be sensitive for identifying people in remission across a range of studies and populations. It can detect changes in remission rates over time it's sensitive to different treatment strategies, and it's still able to capture that patient perspective. And also it's a more feasible tool for defining gout remission. So in long-term gout trials, serum urate, flares, tophus, those are the most commonly measured outcomes. And we see that the pain and patient global assessment outcomes are included much less frequently, unfortunately. And so in analysis of gout trials, a simplified definition can be easily utilized. And yeah, for sure.
I mean, I think certainly for clinical practice, I think it's much, we really like the simplified definition. I think I think the data that we've seen shows that it performs as well as the preliminary criteria. I think it aligns very well, if not better, with the patient's experience. And I think reassuringly, we're not losing the patient perspective. And that may be because actually the experience of flares is so important and such a dominant experience. And it's also much easier to use than, requiring patient-reported outcome measurements over time. So I'm really hoping that we will move towards the simplified criteria for all of those reasons.
And it appears, because you have more responsive to change, which of course is important in every trial. We have to make sure our measurement that the drug can actually improve something that we can measure. When you have such a low response rate, it's really hard to win.
Yeah, absolutely. Yeah.
So in clinical practice, well, I think you answered that with simplicity. Right? I mean, that's
exactly. And simple is good in clinical practice.
Absolutely. The more we put on our patients, the less they're going to do. All right. Or complete what we want them to do regularly. So, but coming back, I guess, to the original trial, really, the clinical implications do you think there are clinical implications that you found in the initial phase using colchicine?
Yeah, and I think this has actually changed my thinking quite a lot in my own practice. So I think that we had known from other trials, including a very important paper published in J. Rheumatol many years ago by Borstad, that colchicine prophylaxis works, and it is useful even when using a start low, go slow approach to urate therapy. So certainly it's made me even more comfortable. It's something that I did use before in my practice, but even more comfortable now using colchicine prophylaxis. I think that there's a couple of really interesting observations that came out of the trial. And I think probably the most interesting thing is this, what happens when you stop with colchicine. And I think we hadn't really seen this in other trials before. And this what looks like a kind of rebound flare. And so one of the things that I do now, which I didn't do before, is actually be really explicit and tell patients that when they stop their colchicine prophylaxis, there is a potential risk of flares, and to, again, make sure that they've got a really good action plan around how to manage that.
Right.
I think it also really raises the question about whether we need longer colchicine prophylaxis, because actually these patients, they were still experiencing quite a lot of gout flares, in that second 6 months. So maybe it's actually that we just need to continue it for a year until, they've had more crystal dissolution. So I think those are the major things. I'm certainly, I've tended to use reasonable lengths of colchicine prophylaxis anyway, but I think I'm probably using it slightly longer as a result, and also making sure that, people are really aware that even if they haven't had gout flares, when they stop with colchicine prophylaxis, there is this risk of rebound, and how to manage that.
Yeah, I think that's very important. Absolutely. So with that, would you like to add anything that I missed or we missed in our discussion?
I guess I would just like to really emphasize, and I think there was a very nice accompanying editorial around this as well, that actually remission should be the goal of treatment. We can achieve remission in many people with gout. It's pretty uncommon in the first year of treatment. So I think this also helps patients and clinicians understand the timelines. And I think it's also very clear from the trials that or the analyses we've done, and from other people's work as well, is that it's much easier to get into gout remission if you don't have tophi. So we do need to be treating with urate lowering therapy, not waiting until patients have very advanced disease and they have tophi, actually starting therapy, urate lowering therapy earlier so that tophi don't develop. Because once tophi develop, actually it takes a long time to get rid of all those crystals. So, I think those are really the messages, and really we should be, trying to optimize treatment to help patients achieve remission, because it's a really great outcome for patients.
Well, thank you.
I don't know if you have any other comments.
Yeah,
Oh, yes. I was just going to mention that in November, we will be presenting data on the simplified gout remission definition at the GCAN conference. So GCAN is the Gout, Hyperuricemia and Crystal Associated Disease Network. And so that will be followed by voting by GCAN members on the simplified definition as a GCAN endorsed definition of gout remission. So that's something to look forward to.
Yeah, so we'll see what the discussion is. We have no assumptions that GCAN will necessarily, or GCAN members will endorse it, but we're really interested to hear the discussion. So we are hoping though that this will become a more widely accepted definition based on the analysis that we've been doing. Yeah,
I look forward to. It's hard to get people to agree though.
Yeah.
Absolutely. Well, anyway, I want to thank you both on behalf of all the author presents. It's very interesting and I think important data, because gout is common. And I think, as you alluded to, a lot of it is managed by primary care physicians. I'm not saying it's a thing, but there is a different goal than rheumatologists have, because we come from different perspectives of what happens in the long term. So anyway, I do thank you, and to our listeners and viewers, please read the complete paper analysis of gout remission definitions in a randomized controlled trial of colchicine prophylaxis for people with gout initiating allopurinol. And as was alluded to, there is an accompanying editorial, and the title really tells it all. Remission is the mission in gout. And it's by Dr. Till Ulrich from the University of Oslo, Norway, and both are available at our website at jroom.org and will be in the November print edition of the journal. And I want to thank you for joining us and hope you'll come back next month when I speak to the author of another article of interest from the December 2024 edition of the Journal of Rheumatology. And if there are any comments, I'd love to hear them, either on X at jroom or by email at manuscripts@jroom.com. Thanks.